Hi everyone, welcome to this NEET SS 2025 Rheumatology recall. I know this would have been a very long journey with initially the NEET SS being planned, then the INISS coming to the fore, before the NEET SS, and it would have been a long journey, especially with all this confusion and then reading for the specialty first and then coming back to the general medicine is never easy. So, firstly, congratulations on completing this journey to an extent, like your preparation for this particular exam, and let's hope for the best with respect to the results as well. For as far as the recall is concerned, we'll be mainly looking at where the questions have come from. For instance, if somebody wants to retrospectively analyze this exam, understand this exam to guide his or her juniors, or probably a junior who is looking at this exam being in an MD medicine, or just about completed medicine and looking at the exam ahead next exam. And even if somebody who could not clear this exam and then understood can understand this exam for the next attempt, right? So firstly, first things first, the weightage, obviously last time it was very high with respect to rheumatology, and it was inconsistent towards rheumatology, as we can say. But this time we all know towards environmental diseases, towards toxins, etc. We'll look at that breakdown as Rahul, Rajiv sir and Karthik sir discussed. We'll look at that again a little bit. PYQ hot topics, I don't think it was any way in with respect to the NEET SS PYQs. There was only one repeat, almost a same repeat that was there. Otherwise, it's very difficult to kind of guess that this was the pattern last time and let's focus on those areas this time. There's a lot of SPA that is asked usually, especially like not maybe the last one or two exams, but before that SPA was a very common topic. Now there are no questions. RA, always at least one question is expected. This time there are no questions. I think only myositis has always been consistent throughout, that something or the other one question they will keep, especially the skin manifestation. That was the only thing that was consistent. But otherwise, you can say, especially arthritis was something that was left out or left out cold, right? Hot topics, very, kind of it'll be clutching at straws because there are 11 questions or so, and I think vasculitis was given its weightage, how much it should be given, and so was scleroderma. This time scleroderma, there were three questions, so I think you can say those were the hot topics this time. From where were the questions asked? Obviously, as we go through each question, we'll see, especially we'll look at the focus on how what topics we discussed, how much we discussed, and how the questions came, and also obviously with respect to the Harrison's textbook, right? So this was how the specialty wise distribution was. We sirs discussed 2 days back, and obviously this was the most weird one. Otherwise, if cardio comes to 25 questions or neurology comes 25 questions, it's understandable because everybody reads them to some extent. But this time it was, I think it was very skewed, maybe towards a little bit towards a critical care part of things, because these are come under a critical care or emergency medicine, you can call that. But otherwise, more or less, few of them had 15 or so questions, and most of the others had around about 10 questions, right? So we'll look at how rheumatology per se has progressed through the years, right from when the first NEET SS of this pattern, that is the 150 all general medicine questions, started. So firstly, there were 10 questions. As expected, I think almost always there are 2 to 3 questions only in SLE APS. Even last year, where there were 29 questions, there were only 2 questions from SLE APS. Usually it is one SLE, one APS. That is how it always is. Myositis 0 to 1 questions. CTD is very variable, as you can look at it here. There were no questions from scleroderma, Jockrins, etc. Now there were 3 questions this time. RA SPA, you expect at least 1 to 2 questions. This time none. Immunology drugs is something that was heavy last time. There were 5 questions from immunology and pharmacology, like the rheumat pharma drugs, but this time again that has gone to zero, right? So this time, as I told you, it was scleroderma there. So I put 4 in other CTDs, which had 3 scleroderma and 1 IgG4 related disease, and 3 vasculitis. I think these were the areas which scleroderma, I don't expect 3 questions, but yeah, this time they were. In vasculitis, you expect 2 to 3 questions, which were like that only. But yeah, this was the major surprise, where almost zero arthritis. You look at the arthritis question, that is also, you can say that's not a arthritis question really, right? So it was skewed towards scleroderma a little bit, and SLE, APS, myositis, vasculitis were how they are expected to be, right? So 29 was definitely too much, and I told you in the last recall as well, but that don't expect 29 questions the next time. It would be a maximum of 15 or so. I think 10 to 15 is what is usually the case. As you can see, 2023 also there were 14 questions, right? Again, it was evenly distributed, and this is what I think you should expect if somebody is looking at preparing ahead, or even trying to understand the exam. Rheumatology is something like 12 questions, and that makes it around about 8% or so. That is one ninth or one tenth of 10 to 15 is one ninth to one tenth of the entire thing, and that is how it should be, right? So this time, as I told you, the questions were from vasculitis, CTDs, almost none from your arthritis, and the miscellaneous questions which again can be put into CDTs or vasculitis. So let's go one by one. Firstly, SLE APS, as I told you, always 1 to 2 questions. This time SLE question was more or less easy, right? So it had two components to the question. Firstly, what is the type of lupus nephritis? Histologically, that was asked, right? Which class of lupus nephritis asked, and what is the most appropriate induction therapy? In this particular case, even if you know the class of, even if you're able to catch the class of lupus nephritis, that should be enough. So here, what is being shown? Endocapillary proliferation, that is one hint. Crescents is one hint, and more than 50% of glomeruli. Remember, we discussed what is endocapillary versus exocapillary. So endocapillary is where the immune complexes deposit towards the surface of the towards the blood side, right? While if it is subepithelial, it is towards the outer surface of the glomerular basement membrane. How does this matter? Because whenever there are subendothelial deposits, the proximity to complements, so this here is blood, right? We discussed this in detail in our discussion. So here there is blood, so the proximity to the blood is more in your subendothelial deposits, and so is the proximity to complement. So whenever there is proximity to complement, here complement fixation occurs. So whenever there is complement fixation, there is a lot of type 3 hypersensitivity, more of inflammation, and more of glomerulonephritis, right? So that is what happens in when there are subendothelial deposits, and or endocapillary proliferation, exocapillary proliferation will be associated with that inflammation. And when there are subendothelial deposits, there are class 3 or class 4 lupus nephritis, compared to when there are subepithelial deposits, there is class 5 lupus nephritis. So along with that, we also discussed focal versus diffuse. Whenever there are more than 50% of involvement of the glomeruli that are there in that area, that is what is diffuse, when we call it as class 4 lupus nephritis, while focal is less than 50%, and that is class 3 lupus nephritis. Segmental versus global is how much of one particular glomerulus is involved. If it is more than 50% of glomerulus being involved, that is global, and if it is less than 50% being involved, that is segmental, right? Again, there is also a little bit of complication with respect to what is 4S versus 4G. So this is where more than 50% of glomeruli have segmental lesions, then you call it 4S. While if more than 50% of glomeruli have global lesions, that is 4G. This is a little bit in there, but it's important because this is the table, this is Harrison's table itself, and this is given in that. Active versus inactive lesions are a different thing. Whenever you have crescents, so here as you saw, although it didn't matter for this particular question, but yeah, in general, whenever you have crescents, whenever you have interstitial inflammation, whenever you have fibrinoid necrosis, there are the 6 things that we discussed. Whenever you have karyarexis, whenever you have leukocytic infiltrate, hyaline deposits, all of these come into active. While inactive is when you don't have anything. While chronic is like interstitial fibrosis, tubular atrophy, glomerular sclerosis, fibrous crescents, all of this come into your chronicity, right? So that is one important thing. And the subendothelial, subepithelial, based on these things that were given in the question stem, you could zero in on class 4 lupus nephritis. Didn't matter here, but treatment was also asked. So treatment we discussed with respect to class 3, class 4, induction was asked, right? So firstly, you have to obviously consider pulse steroids, especially if there is hypertension, if there are crescents in the biopsy, if there is fibrinoid necrosis with casts, RBC casts, if there is nephrotic range proteinuria. All of this will make you decide whether you will give just oral steroids versus pulse. And after giving steroid dose, you will consider your main immunosuppressive induction agent. So this is KDIGO based lupus nephritis treatment that I taught you in the videos, but the next videos that the next guidelines that came about, the 2024 ACR guidelines and the EULAR guidelines of this year itself, they suggest triple therapy, right? So triple therapy has what are called three things. Firstly, the steroid itself, then you have MMF. MMF is what is recommended, but you can also use ELNT cyclo. Plus, either you use a calcineurin inhibitor like a tacrolimus, or a cyclosporin or a voclosporin in certain cases, or you can use belimumab. So this is what is triple therapy, and there are other additions as well. Sometimes you can use what is called obinutuzumab also, which is a CD20 agent similar to rituximab, right? So this is what is triple therapy, which is now recommended, but obviously they didn't ask all this because again, that's just one of the guidelines, right? It's not like that is the gold standard or something. So here, corticosteroids with cyclophosphamide or MMF is the induction therapy that you use. Yeah, so this is with respect to summary of initially you treat with steroids and then you give either of the induction agents. So this I think was very I was really disappointed with this question. It was definitely not an evidence based question, right? So here what he or she is asking is triple positive antiphospholipid antibodies, asymptomatic, no obstructive morbidity, no obstetric complications given, no thrombotic complications given. So essentially asymptomatic patient with lab positive APS. Firstly, it's very weird to have such a patient in your OPD or what, because why are you doing an APS? Probably you're doing an APS because the patient has a CTD, probably an SLE or a Sjogren syndrome, right? Sometimes we do in Sjogren syndrome as well if you're suspecting a secondary APS, right? So especially in SLE, we do it, for all patients. Probably there is an SLE, but again, that is not mentioned here. And here, what is asked is management for prophylaxis. This was the exact statement that was asked. So, firstly, what is evidence based to an extent? That too, it's not very robust. To an extent, evidence is aspirin, but all had aspirin. But the thing is, ideally, you should have marked this correct because clearly evidence says that you do not need to anticoagulate the patient, right? So that way, all of these are eliminated and you can mark A because A is definitely the right option here. But why you're giving HCQ is not at all clear in this particular case. Just assuming that this might be an SLE for whom the labs have been done just because he or she is an SLE, and they come out to be positive. That is the assumption under which HCQ is being given here, right? So this is what we discussed. This is the only table I feel that you should remember. This is the Kelly's rheumatology table, which kind of makes it pretty simple on how to understand APS treatment. So firstly, you have to kind of break down the kind of patient into either thrombotic APS or obstetric APS or miscellaneous like the other non-criteria manifestations we call it, either thrombocytopenia or catastrophic APS, other things. Here, what was given is asymptomatic, right? Let's go to the proper table itself. So asymptomatic was given, and as you can see clearly, Kelly says no treatment. However, there is a superscript that brings, there's a thing that is given here, and that says aspirin may be considered in high risk patients only. Here, there is nothing given as high risk patients or any comorbidities, nothing is mentioned. But yeah, still, aspirin was given in all the options. There's no mention of HCQ. HCQ can be given when, see, so while HCQ appears to be protective against thrombosis in APL positive SLE patients, here there's no mention of SLE as well. Its role in APL positive without systemic autoimmune rheumatic diseases remains uncertain. So just assuming that SLE is there, yes, aspirin plus HCQ is better option, and also the other options are definitely wrong because you don't need to anticoagulate this patient, right? So that's why A is the best answer. I think this was one of the easier questions. I don't think, uh, because P-ANCA positivity is given, negative anti-glomerular base membrane antibodies are given. So like these two are ruled out. Lupus nephritis definitely not, fitting into this, especially with P-ANCA positivity. Yes, can be there, but there's no uh, clinical thing that pushes you towards thinking that it's lupus nephritis. So microscopic polyangiitis, there is rapidly progressive renal failure, diffuse alveolar hemorrhage, which was also given. Mononeuritis multiplex was not given here, but yeah, there's not much given. Mainly I think this was a very loosely framed question, lazily framed question with just P-ANCA positivity, and options were also pretty simple, right? You can rule out most of the options. Yeah, this was little bit tough because when we discussed cryoglobulinemia, I just told you verbally about how to treat. But I think this has been after that, I think wasn't really, explicitly put in the notes, etc. And that is why many of you have been asking about cryo treatment in our groups. And as you can see here, just I think a few days before the exam only, one of the students asked this particular question only on how to treat cryoglobulinemia. This is like, I think, 3 to 4 days before the exam. And if it is very severe, then immediate next step should be either steroids or plex. Otherwise, if it is just severe, then it will be rituximab. If it is non-life threatening or mild, then antivirals. This is with respect to HCV vasculitis. Even a few months back, same thing was discussed, the treatment of cryoglobulinemia vasculitis. So as you can see here, if it is very severe or life-threatening, high dose steroids or plex or cyclophosphamide also can be considered. Severe, then rituximab. Non-severe or non-life-threatening, HCV antiviral. So that is how you treat here HCV associated cryoglobulinemia vasculitis. And if even if you do not know all of this breakdown of severity based approach, this was a direct line from Harrison's itself. So when there is HCV, this is actually not accurate, because if a patient comes with HCV with cryo, very severe life threatening, you don't just give antivirals as first line. Antivirals you have to give, but the first line or the immediate next step is not antivirals. The immediate next step will be plex, right? But yeah, even if you didn't know all that, if you just read your Harrison this line and went, then also you could have got this correct. This was again a very, I mean, weird question. I'll tell you why. So firstly, I'm not sure if the diagnosis was given or not, but it's pretty straightforward. But coming to the options, right? So temporal artery biopsy must be performed before immunosuppressive therapy. Nothing like that, because especially when there is, like, I mean, vision threatening illness, especially when there is painful vision loss, then immediately you have to pulse the patient. So you do not wait for temporal artery biopsy. Yes, that is there, that you will do it ideally within 2 weeks. Like, temporal artery biopsy is the gold standard. And just a second, yeah, so it should be done within 2 weeks of starting steroids, and you have to take at least 1.5 centimeter. That particular thing is there, but it's not like temporal artery biopsy should be done first and then you give steroids. So this is definitely wrong, right? So next we come to this: corticosteroids have inferior efficacy compared to abatacept. Again, this is clearly wrong, and if we discuss this in our treatment as well, abatacept we discussed in treatment, as this is one of the things that is useful and it is proven to be better than steroids in GCA, but not the case in Takayasu. We discussed this in proper detail. But even if you see Harrison's clear sentence is given that it has demonstrated greater efficacy than steroids alone, right? So these both are okay. Now we talk about methotrexate has a proven steroid sparing role, and cardiac involvement is a major cause of mortality. Now first, let's go by evidence, right? So evidence, there is meta-analysis evidence from RCTs of methotrexate saying that methotrexate does decrease the usage of steroids, decreases the dosage of steroids, which is essentially what steroid sparing means, right? So if you look at meta-analysis, if you look at latest data, yes, this should be correct. But now let's go to see what Harrison says. Harrison says that there are two RCTs that reach conflicting conclusions with respect to methotrexate as a steroid sparing agent. Now again, if they are going only by Harrison's, then there is no sentence to suggest that this particular sentence is true. And if they're going by evidence, then this should be true. And when you come to D, there's no very robust evidence. Cardiac involvement means what? Does it involve cardiovascular involvement? If it's cardiovascular involvement, I would definitely have lean towards option D. But it says just cardiac involvement. Again, does it involve aortic dissection? Not sure, right? So does it? So that's the reason why I think B is a better option, because we have strong evidence to say that methotrexate has proven steroid sparing role. But again, if somebody goes and just picks up the line from Harrison and says no, this is wrong, we can't say, right? But I feel that B is a better option at this point of time. And I hope these were the exact recall, which I hope I believe so. Right, coming to other CTDs, I think we are now coming to the lesser controversial parts of the Rheumat paper. I think this was pretty simple. The stem was whatever, either it was some students recall that it was LCSSC, some students recall it as BCSSC, diffuse, whatever it is. The final question was, again, yeah, so this also there is a little confusion whether the final question was more strongly associated or it was protective. If it was protective, then B is the answer. But most of the students, Yeah, so most of the students say that this was asked, that is more strongly associated was asked, and if that is the uh, thing, then anti-RNA polymerase 3 is the better answer, right? So now SRC has slowly decreased in prevalence, that we all know, but again still questions keep coming on SRC itself, and risk factors are very important. Harrison itself says clearly that RNA polymerase 3 is the one that is increasing the risk of SRC, while your anti-centromere antibodies will protect against SRC. So it depends on what question was asked. Most of the students gave me the question saying more strongly associated was asked. If protected was asked, anti-centromere. If strongly associated was asked, anti-RNA polymerase 3. This is a repeat. This is a direct almost a direct repeat. I think in 2024 one of the option had bosentan, I think. Otherwise the same 50%, 65% same things are given. Also last time I'm not sure if HRCT was given or X-ray was given, so these both I have a doubt, but otherwise it's the same question again. And yeah, so what is the appropriate disease modifying treatment? It's again definitely it's set by somebody who hasn't read the ERS guidelines, because it's very difficult to say what is the appropriate disease modifying treatment, because there also there is a strong advocacy for calcineurin inhibitors along with cyclo or MMF, but it's okay. Most of the other options are definitely not fitting. SSC ILD best treatment, especially with a DLC of 50%. You can say MMF or cyclophosphamide. Yeah, even nintedanib, there's no mention of nintedanib in the options. So yeah, question maybe a little bit here and there, but the options were pretty straightforward, right? So MMF or cyclophosphamide is what Harrison says, with or without nintedanib, depending on if there is fibrosis or not. So this I think is more of a GI question, like per se. But yeah, so firstly you have to understand what is the. I'm not sure if the diagnosis was given, if the diagnosis was given or not. So basically it is SIBO. So why does it occur? Firstly, systemic sclerosis causes a lot of smooth muscle atrophy that leads to dysmotility, that will lead to stasis in the small intestine, and that will lead to bacterial overgrowth. And we know why B12 is low, why elevated folate is there, because basically the bacteria will synthesize a lot of folate, will take up a lot of B12. That is why that happens, right? Yeah, so we discussed this with respect to dysmotility and SIBO. And best diagnostic test was asked. So best diagnostic test is the lactulose hydrogen breath test. It is a non-invasive test. It's widely used for screening, for diagnosis, for SIBO, and early hydrogen rise is what is seen. Early hydrogen rise after you take in your lactulose, and this indicates proximal bacterial fermentation, right? So the bacteria is fermenting lactulose, leading to a lot of hydrogen release. And yeah, so why are the other options wrong, right? So ammonia breath test not used for SIBO. Duodenal biopsy, it may show some non-specific changes, but again not anything which is specific to SIBO, nor is your colonic biopsy, because obviously it's not a small intestinal pathology, right? So it's a small intestinal pathology, it will be normal with respect to colon biopsy. So if you just caught SIBO here, I think you would have answered this. I hope you didn't get it confused with ammonia breath test, but otherwise it was a more or less straightforward question. Yeah, autoimmune pancreatitis, I think this was little bit weird, because if somebody read the Harrison in depth, then definitely you could have got this correct, because there's a small hidden paragraph about autoimmune pancreatitis being called type 1 autoimmune pancreatitis. If you've read this in gastro, that's even better, type 1 versus type 2, etc. But otherwise also, if you have read only the IgG4 related disease of what we discussed, that should be enough. So they've asked multiple statements, again shows so firstly you should know that type 1 is in IgG4, type 2 is not in IgG4. Type 1 shows a predominance is in males, correct, around 2 is to 1 to 3 is to 1 ratio is there. Lymphoplasmacytic infiltrate with stoiform fibrosis. So that is the classic triad that is there in pathology of IgG4 related disease. We discuss the diagnosis as well, where we have dense lymphocytic infiltrate, stoiform fibrosis, etc. And yeah, so we discuss about type 1 autoimmune pancreatitis, which has sausage shaped pancreas. So here what was asked otherwise, which was the wrong statement, is type 2 is associated with retroperitoneal fibrosis. So again, you have to understand that retroperitoneal fibrosis is seen in your IgG4 related disease, uh, and that is associated with type 1 autoimmune pancreatitis. That is all you need to kind of figure out, and you can eliminate that statement. Just a side note that retroperitoneal fibrosis or Ormond's disease is a subtype or a phenotype of IgG4 related disease, which usually has normal IgG4 levels. So I think IgG4 has been asked after a break. I think it was asked in 2021 or so, and in between it wasn't asked. But yeah, we have a 30-minute discussion. You can definitely go through that. This I think is the simplest question again, but again, there is uh, a mistake, if I can call it, because this is actually best described as a Gotran's papule. But supposedly there was no option of Gotran's papule. If there was Gotran's papule and Gotran's sign, if ever there was, then definitely Gotran's papule would be the best answer here. I got this image itself saying that this was what was asked exactly. I hope that's right. So here there's no Gotran's papule, so that's why Gottran sign should be the best answer, right? So Gottran sign is anything that is not present on the knuckles and that is not a papule. That can be a plaque, that can be a macule, etc., which is looking uh, pink, which has probably some telangiectasias over it, which is itchy. So all of these are classic features of your Gottran's sign, which is not on the knuckles, which is not papular in morphology, but has all these features. That is Gottran's sign. Here it is a papule. Here it is on the knuckles. So ideally, it should be a Gottran's papule. Right, so we'll discuss this in detail, how to differentiate SLE again. So ACLE was given here, so maybe they wanted to test that if somebody wrote ACLE, but when you're giving an image of knuckles, most probably everybody should have marked Gottran's papules only, right? So what is the difference? The main difference is that knuckles are spared in ACLE rash, the areas beside the knuckles that are involved, while in your Gottran's papules, it is mainly the knuckles that are involved. The other thing is your pruritus. Dermatomyositis is notoriously very pruritic, while if you look at the SLE, it's not so pruritic. There sometimes it's said SLE is a little bit more painful than dermatomyositis, while dermatomyositis is significantly more itchy than your SLE. Right, so this I think was the only arthritis question, and it's not really rheumat question per se. I think you can pause and go through this one pager of Whipple's disease. This was a middle-aged man with migratory intermittent non-erosive arthritis. There was diarrhea, weight loss, abdominal pain. So all of these are your common signs and symptoms. I think hyperpigmentation was also given in the stem, if I'm not wrong. So skin hyperpigmentation is seen, and usually you have PAS positive macrophages that are seen in the histology, right? So this is with respect to Whipple's disease. Right, so this was, as I told you, this time a little bit of a correction happened with respect to rheumat, which was expected. You're not going to get 25 questions, 29 questions every time. This is how it will be. Around, I think, 12 to 15 questions is what rheumatology will have. That's what this means. Paper, I think rheumat was moderate only. I don't think any question was very tough or anything. I think I would say the GCA question was a little bit tough or confusing with respect to a few options, but otherwise it was more or less okay. And I'm not sure if it was very Harrison based also. Some questions, as we saw, I think some statements were directly picked up from Harrison's, but there were a few things that are not given in Harrison's as well. Like for instance, even type 1 pancreatitis, there is no clear distinction in IgG4-RD. There is no clear given that this is type 1, this is not type 1 or type 2. There's no real table that is there, right? So clinical importance is important. This time, I think last time we had 29 questions, but repeats plus our allied TNDs, I had checked it, there were only 3. This time we had more of I think repeats. One clear direct repeat was there with respect to SSC, ILD and TND, allied TND also we had 3 questions, right? So that we kind of, it was a better paper if somebody has done only these. Line by line Harrison's, I'm not sure, because yeah, if somebody is able to do it, that is the best way to do it, but again, it's easier said than done, right? So I think clinical questions were there this time. A little bit more of evidence based questions were there, image based questions were there, right? So it was more of a mixed paper, and I would say moderate paper with respect to rheumatology. So all the best to everybody. I think uh, it was a paper that was tough for everyone, especially with respect to environmental medicine and everything. For example, last time what happened was, last time rheumat questions were a lot, and if you see the counseling also, those who were probably very much inclined towards rheumat did very well in the exam. So that is why top 10 had 4 rheumat, people who took rheumat, and even top 20 had, I think, around 7 8 people who took rheumat. So whoever was probably preparing for INS is probably inclined towards rheumatology. They did very well in the last year's paper, but this time it's unlikely that somebody would be inclined towards environmental medicine or something, right? So that way I think it was a leveler. That unexpected question, component was a leveler for everybody, and I think you should be confident of how you did in the other questions, then you would fare very well. So thank you. Meet you on our group or in the videos.